Hi, I'm Jessica McLaughlin. I'm one of the REI physicians here at Coastal Fertility, and welcome to our final installation of our patient seminar series, which we are doing virtually through YouTube. Today, we're going to be talking about oocyte cryopreservation, which is the fancy name for egg freezing. And so I met some of you on our first webinar together. And just to tell you a little bit more about myself, I'm originally from Vermont. I grew up there and then transitioned over to Texas, San Antonio, Texas. I did my training and practice there. I have fantastic mentors, physicians, and colleagues. And then I wanted to get back to the East Coast, but stay warm, and Charleston was a perfect place for that. And so I've been with this practice for about a year and a half. It's been a wonderful experience. My husband and I have two wonderful little girls, and really my fertility, my family is so important to me. And that's why I love doing this job. And it's really a privilege to be helping women and couples through this journey. And so today, like we said, we're going to be talking about egg freezing. Specifically, we're going to talk about why to consider egg freezing, when is the optimal time that we should be freezing eggs, and what the actual process entails. So we'll get started. So what is all the hype? We have certainly been hearing about egg freezing more and more. And really, the first baby born through a frozen egg was born in 1986, but a lot has changed since then. And a new freezing technique has really led to higher success rates. So this is something that's really revolutionized our field called vitrification. The process of freezing eggs is actually very challenging. And in the old process, which we'll talk more about, the slow freeze, we were not that good at it. But with our new technique called vitrification, the overall success rates have really improved. And there was a study in 2011, a big study that looked at pregnancy rates comparing frozen eggs and fresh eggs and found that they're really very similar. And so based on this big study, our governing society, the American Society of Reproductive Medicine, re-looked at the guidelines. And so egg freezing used to be, for the general population, considered an experimental procedure, but it's really now standard of care after this big study that shows really fresh eggs have really similar outcomes to frozen eggs. And so in 2012, the American Society for Reproductive Medicine took off that experimental label. So it used to be that I thought of egg freezing for fertility preservations really only in my cancer patients that were about to undergo chemotherapy. But now something called planned oocyte cryopreservation or egg freezing really can be considered for anyone. And we'll talk about who maybe should specifically be considering that. So why should I freeze my eggs? We really find the answer when we look at this graph. And I think this is a graph that has been shown in a couple of the other seminars, but it really is important to understand what natural fertility does and what happens with age. So on the y-axis are the percent fertile and the age on the x-axis. And so really surprisingly, actually natural fertility starts to go down a little bit in the late 20s. We see that curve really become quite steeper in the 30s. And when we get to down here by age of about 44, 45, really 99% of women are infertile. And this is a very natural process. And we know this is related to both a decrease in quantity of eggs, but really importantly also a decrease in the quality of the eggs. And so when we think about the decrease in natural fertility, that also translates into the decrease in IVF pregnancy rates that we see with age. So here again on the y-axis is the pregnancy rate and the age is here on the x-axis. And so overall, IVF success rates will go down with age. And so the curve again really starts to become steeper in the 30s and especially late 30s. And so what this brings up to us is there some time in here before we're seeing this decrease in natural fertility, a decrease in overall IVF success rates that we could be intervening. And that's where we start thinking about egg freezing. So who is a candidate for egg freezing? Well, certainly newly diagnosed cancer patients prior to chemotherapy and radiation. So the ovaries themselves are very fragile structures, fragile organs, and they are very susceptible to chemotherapy and radiation. So chemotherapy is going to be toxic to the ovaries, and the ovaries really feel quite an insult from chemotherapy and radiation. So we are often and always have seen patients before chemotherapy and talk to them about either freezing eggs or freezing embryos. So that's, certainly originally who we thought of this technology for. But more and more, we're seeing a trend towards women desiring, whether that be a planned or unplanned desire to delay childbearing. Really, the time is not right. It could be that we're focusing on careers or other personal aspects of our lives. And so, really, egg freezing is considered standard of care for fertility preservation just for women that want to delay childbearing. I also do egg freezing for patients that have maybe some ethical or religious beliefs against freezing embryos. So this, as an example, could be a patient that is undergoing an IVF cycle, and we only fertilize a few eggs so that don't have a surplus of embryos. So we could just fertilize a few eggs, and we could freeze the remainder just as eggs. I also use it as a technique to salvage an interrupted IVF cycle. So the example would be I have a patient going through an IVF cycle, and for whatever reason, the day of egg retrieval, we do not have sperm available. And so the way to kind of salvage or save that cycle is just to freeze eggs. And really, we're freezing a lot of eggs for women who are choosing to donate their eggs. So women who are anonymous or actually known donors going through an IVF cycle, and we're freezing those eggs to be a donor for someone else. So egg freezing is actually a form of in vitro fertilization or IVF. In general, that pre-testing or coming in to see the physician, getting the initial test, that's going to take approximately a month. And then we're going to kind of get into the heart of IVF. And so we'll talk about kind of each of these in more detail, but usually IVF starts with a birth control pill for approximately 10 or 12 days. And then we're moving on to injectable medications, and that's also approximately 10 to 12 days. Ultimately getting ready for an egg retrieval. That is a procedure that's done just in our in-office OR here. You're going to have light sedation, and the procedure itself takes about 30 minutes. The eggs are then frozen, and most of my patients are really back to work the next day. So that's a very kind of brief overview, about a month of pre-testing, then approximately a month to do the IVF cycle itself. So what is involved in the testing beforehand? So this would be coming in and meeting. We have 4 physicians here, or meeting with one of our physicians, and we're just going to go through a medical history, talk about your medical, your surgical history, etc., making sure you're healthy enough, and that egg freezing is a good opportunity for you. We're also going to do an ultrasound that we're going to look at the uterus, we're going to look at the ovaries, and specifically with the ovaries, something that we're looking at is this antral follicle count. And that's really our first bullet point here on ovarian reserve testing. So one of the important parts of testing beforehand is getting an assessment of ovarian reserve. And I think this is something that Dr. Slowey talked about in more detail in his presentation. But ovarian reserve refers to your overall egg quantity and quality. And as females, we're born with all the eggs we're ever going to have, and it's just naturally going to decrease throughout our life. A very natural process, we know that. But we just want to see where you are in that process. So getting an estimate of your egg quantity and quality. And so we do this in a couple of different ways. And like we said, that first one is the antral follicle count. It's going to be your physician looking at your ovaries and counting the number of little resting eggs that we're seeing in the ovary. In general, I like to see about 8 or so. Less than 4 would certainly be low. And so that's something that we can look at ahead of time. The other thing we're going to be planning to get is what's called a day 3 FSH. And FSH stands for follicle stimulating hormone. It is the hormone from the brain, comes from the brain, goes down to stimulate the follicles. It is a marker to me of how hard your brain is having to work to push your ovary. And so that's a really important lab to get beforehand. And the other one that we get is something called anti-Mullerian hormone. AMH is actually produced from those tiny little microscopic eggs that we're seeing in the follicle. And therefore, it is a great marker to me for egg quantity. And so I like to take all three of these things, antral follicle count, day 3 FSH, and AMH, and really put them all together to give me an estimate of your ovarian reserve. And I think this can really be helpful in addition to your age, when we start to think about what do we expect from this IVF cycle, and from a physician standpoint, what medicines am I going to use and at what doses. So ovarian reserve testing is very important. The only other thing that we get beforehand is just some infectious disease labs. This is HIV, hepatitis, etc. And these are just ordered because we're going to be storing your eggs in our lab. So now we've made it to the IVF process, and like we said, most of the time that actually starts with a birth control pill. And I know that sounds completely counterintuitive, but the birth control pill is a short course of birth control. It is going to kind of quiet the ovary down so that when we start growing all the follicles, everyone is growing together. So it leads to kind of a nice synchronized cohort. And then we're going to start that injection medicine. And the injection medicine is giving you back the brain hormone. So FSH and LH, like we talked about, FSH is that follicle stimulating hormone. We're just giving it to you as a little injection. And this is the more intensive portion of IVF. This is where we're seeing you quite frequently in the office to really monitor your labs and your ovaries. And ultimately, we are getting ready for an egg retrieval. So what the medicine does is it's going to grow each one of those follicles, and they're going to become these big black circles that we're seeing on the screen. So during an egg retrieval, once you're nice and sleepy with anesthesia, we're going to put, with a vaginal ultrasound, a little needle is going to go into each one of these fluid pockets. It's really just an aspiration device. It's just going to pull out that fluid, and that has the egg. And we're going to hand, directly that fluid off to the lab. Our OR is very unique. It's an OR that's directly attached to our embryology lab. The embryologists are going to take the fluid and they're going to identify the egg that's in the fluid. And then comes the tricky part. How are the eggs frozen? And so, like we alluded to a little bit, freezing eggs is a very actually technically challenging process. And the reason behind that is that eggs are actually mostly water. So with our old process, this really slow freeze, what happened is that we got a lot of ice crystals within the egg, and that was very harmful or toxic to the eggs. And overall, it's this ice crystal formation that led to lower success rates with this slow freeze. So our newer technique called vitrification takes water to a solid in a very quick or flash freeze step. So the flash freeze or vitrification has, like I said, really revolutionized our field and led to greatly improved success rates with frozen eggs, so much so that they, like we talked about, have essentially equivalent success rates as fresh eggs now. And really, those eggs can be frozen indefinitely. You may be ready to use them in a year, or you may be ready in 5 years, or you may be ready in 10 years, and all those are okay. There's no specific timer on the freezer. And so once they're frozen indefinitely, and they are frozen at whatever age you went through your IVF cycle. So let's say you come back to see me in 5 years and you're ready to use your eggs. What would that process look like? Well, first we would get you up to date with your prenatal labs. We would do an assessment of your uterus and make sure that we were otherwise ready for an embryo transfer. And so we would thaw the eggs in our lab and we would combine them with sperm. And then fertilization is going to occur in the lab, and we will be watching those embryos grow and divide. So embryos are going to start, they're going to go 2 cells, 4 cells, 8 cells, etc. They're going to be dividing in the lab. And there's sometimes we're transferring back on day 3, and sometimes we're growing out to the day 5 stage, called that blastocyst stage. But really what an embryo transfer is once the embryo is at an appropriate stage of growth, that little embryo, just with a little catheter, goes into the mid-top of the uterus. And that's a procedure that doesn't involve anesthesia. You've already done all the hard work. And then, we're usually getting a pregnancy test in about 9 days. And so that's what that portion, looks like potentially in the future. So the next question is, when should I freeze my eggs? When should I be thinking about this? And so, of course, a younger age at freeze leads to better pregnancy rates. But remember, looking back to that graph, an ideal age seems to be somewhere between 30 to 37. That's where we saw that line becoming steeper. And when we think about live birth rates, which is ultimately our goal for you, those live birth rates are about 50% when patients are using frozen eggs before age 35. And again, that's very equivalent to if a patient under 35 went through a fresh IVF cycle. We can consider egg freezing in younger patients. And so who I think about this specifically in is a younger patient. If they've been found to have diminished ovarian reserve, let's say, we have a 24-year-old with known diminished ovarian reserve, certainly that's someone that we would recommend freezing eggs in. The other patients we think of, just looking at your family history, if you have a very family history of early menopause, I think that's also a good reason to be thinking about freezing eggs. And like we talked about, certainly, at any age, if we're receiving what we call gonatotoxic therapies, so that chemo or pelvic radiation that's going to be toxic to the ovaries. Patients older than 38 may just have varying responses to the stimulation and require more eggs to have a reasonable chance at live birth in the future. And so we know as women age, they are going to require more eggs because that egg quality is going to naturally go down with age. So I don't think it's off the table after age 38, but I think that's when we really see a varying response, and we'll be kind of looking more at your ovarian reserve, etc. So how effective is it? How good are we at this? So this is a study that combines 17 different studies together. And so when we think about how many eggs are going to survive the thaw, we anticipate about 88 or 90%. The fertilization rate, which is how many fertilize after we combine egg together with sperm, is really in the 74-75% range, which is what we would anticipate, again, using a fresh egg. When we think about ongoing pregnancy rate per egg, it's about 7%. And of course, this is going to vary a little bit with age, your ovarian reserve, etc. But the general principle is the more eggs frozen, the higher pregnancy rates. And so a question that I often get from patients is, how many eggs do I need? And so that is really going to be different for everybody. I think, in general, if I have a patient in their kind of mid-30s, I think 15, somewhere around 15 is a reasonable number. But again, that is all going to be very dependent upon your age, your ovarian reserve. And that's why we really, on that initial consult, look at you as an individual patient. Certainly nothing is black and white. And when we look at outcomes after using those eggs, there's no increased risk of miscarriage. The miscarriage rate is about 20%. That is what natural miscarriage rate is in the general population. And there's no increased risk for birth defects. And so I think this is reassuring data for us. And so this is, again, is some of the things that help the American Society for Reproductive Medicine make this a standard of care. I'm going to pause just for a moment. We just have one question.
Yes. So Meadow wants to know, how does the rapid freeze prevent damage to the eggs or the embryos?
So the rapid freeze, using a couple different solutions, just like the name suggests, a flash freeze. During the slow freeze, because it's taking so long to go from the water to the solid, that's where we get the ice crystal formation. But in the flash freeze, we have no ice crystal formation just because of the different solutions that are being utilized. So it's rapidly going from water to a solid state, and that little egg doesn't have that toxic effect from the egg crystals. But good question. So what about our experience with egg freezing? So we have the largest egg freezing program in the state of South Carolina. And this has a lot to do with our association with Donor Egg Bank USA. And so we contribute a large number of donor egg cycles to Donor Egg Bank USA. And this has really helped us to refine this technically challenging process. And we are proud. We have physicians that have helped with the first, second, third babies born in the state of South Carolina from egg freezing. And I cannot stress enough with egg freezing, experience really matters. So, as a prospective patient, something to look at is what is their volume that they do of egg freezing? Because with egg freezing, they're technically much more challenging to freeze than just freezing sperm or freezing embryos. This is more technically challenging. So having a high volume, having the experience really does matter. And so we are one of only 16 centers in the nation to have the egg freezing seal of assurance, and we are the only site here in South Carolina. This is our head embryologist, Dr. Gray, who is also our lab director, and he was recently awarded an embryology award for egg vitrification from Donor Egg Bank USA. This is a very prestigious award. And I think it really speaks to who we are. We are really kind of doubling down, focusing on the lab so that we can give you your best eggs and best overall success rates in the future. And so my thoughts, I think having a child is of great importance to many women. I think that as a woman, we think about this probably our whole lives. We're thinking about this as a child and as we're growing up. And women are starting to have children at later ages, and sometimes that's by choice and sometimes not by choice. I think we, are focusing more on jobs, on career, or we're doing longer times in school, more schooling. And so, sometimes having a family takes a back seat to that. Overall, I think there was poor knowledge of true reproductive aging, and it's been shown that women really regret not knowing or not acting sooner. And I can certainly say, from seeing patients in my office, a lot of patients just didn't know that's really what happens kind of with natural fertility, and that's of no one's fault whatsoever. But I think it's just something that really isn't talked about that much. And so I think with all this said, I think it's at least worthy of a discussion of reproductive aging and options. And that's what we're here for, really. The door is open, and we'd love to talk with you about it further. And so with that, I will conclude my talk. We are available online, calling, also, and getting in for that new patient appointment is really kind of that first step. You have really an hour with a physician, and then you meet with a nurse and also a financial counselor. And so we would love to work with you in the future, and we're here for you for that. So with that, I'm going to conclude my talk. I hope everyone has a great holiday season. So Merry Christmas, Happy Holidays, and a Happy New Year.